I think this is a topic which is very relevant, and also it has implications going well beyond the current COVID situation, which I hopefully will clear away in the coming months. But it is also related to the care of non-communicable diseases, which is a major issue in all countries worldwide, and also the use of new technologies, innovative ideas to improve the quality care of these diseases. First of all, I'd just like to set some housekeeping rules. We have a relatively short period of time today, so in order to make sure that all the presenters will be able to make full use of their time, I will ask the Q&D session to be held at the very end. And I will also ask the presenters to kindly keep within the allocated time which is given to them. With that, I would like to hand over this to Oliver Richards, who will give welcoming remarks to this event. Thank you.
Thank you very much, Takeshi, and it's great pleasure to be here with you all. I think my role is to extend a very warm welcome from the UK government to all of our guest speakers and to the audience. Thank you very much for joining this important webinar. I think as Takeshi has already said, we are very much framing the way we look at healthcare responses through the pandemic. And I think it's really interesting to understand just how important non-communicable diseases have been to actually risk in the pandemic. So I think it's great that today we're having a focus on that. And I think it's great that we are bringing together the best of UK and regional expertise to discover and think about how we can work together in that area. There are, of course, some good political momentum behind this. The G7 this year, which was hosted by the UK, will create a stronger global health system to protect us from future pandemics. So let's think about how non-NCD responses can help with that. And then, of course, here in Indonesia specifically this year, we have the G20. And so there's a huge opportunity again for our Indonesian colleagues especially, but our regional colleagues too, to think about how we can generate some momentum behind good, solid healthcare responses, not just things like vaccines and therapeutics, which are important, but also what about the NCD space? And back to the UK, I noticed recently we have a really interesting new UK life sciences vision, which we set out in July this year. It covers all sorts of things like dementia, cancer vaccines, dealing with cardiovascular factors like obesity, respiratory diseases, a huge range of issues. And I think that therefore there's a lot of investment and a lot of R&D going into this in the UK. And I hope that there's a lot that we can learn from the experts on the call today about all of that. So I know that time is brief. I won't take up any more time than that, Takeshi, but I just once again to extend a very warm welcome and to wish you a very successful webinar. Thanks, and back to you.
Okay, so without any further ado, I'd like to go to the first presentation, which is from Dr. Pukovisa Prawiroharajo of the Mandai Royal Hospital of Puri, Tangerang in Indonesia. Excuse me, I'm not quite used to these names quite yet. I will improve. So without further ado, Professor, Doctor, can you go into the first presentation? Thank you.
Thank you very much, Oliver, Mr. Oliver Richards, and also Takeshi Zura for introducing me. Good afternoon to all of participants, speakers, and committee in Indonesian time. I'm Pukovisa Prawiroharajo, a neurologist, and I'm actively researching in Universitas Indonesia in the neurobehavior diseases field. And I'm representing right now from the Mandaya Royal Hospital Puri, and it's an honor to be involved in this discussion. In today's level discussion, I will be showing some general view as to how the non-communicable diseases have been managed in this pandemic era in Indonesia, especially maybe in a generally what we can do as of effort in the Mandaya Royal Hospital Puri, and also innovative from Universitas Indonesia. Before we begin, I would like to thank you for the opportunity to share this to all of you. we can lead a fruitful discussion. Next slide, please. So next slide, please. Yeah, Indonesia itself, as we all know, is a large archipelagic country with magnanimous population of more than 255 million people, standing as the world's fourth most populous country. And as Mr. Oliver said, that we are included in the G20. This characteristic brought itself factors affecting our healthcare management. Next slide. And we know that from the WHO showed that 70% of the current deaths were caused by NCD, whether they are from cardio and cerebrovascular diseases, cancer, chronic lung disease, diabetes, chronic neurological disorders, or others. Next slide. And the picture is also consistent in Indonesia, whether the NCD as a causal death is increasing in recent years. We get the data until 2014, and it is all increasing right now. Next slide. Before the pandemic hit us, there's our approach in managing and preventing NCD, which focus on partnership, community empowerment, health service capacity strengthening, surveillance, and research. Slide. We also push the intersector involvement and support in managing NCDs, as for examples are the Healthy Lifestyle Movement or GERMAS, Gerakan Masyarakat Sehat, Global Actions Target, and policy measures by the government. Slide, please. And we also do the community empowerment, where encourage with initiation of post-bindu or post-bina penyakit, and healthcare extension to every village, focusing on NCD with the help of local residents, set on workplaces, school, or other public places. Other approaches that taken were engaging NGO, private sector, social media, and app-based approach. Slide, please. By 2016, there were already over 18,000 post-bindu or like a health center for the NCD across 34 provinces in Indonesia. Next slide. And also by 2016, over 9,000 health centers have been implemented with NCD essential package services in an attempt to strengthen health services capacity. Slide. Now, since the COVID-19 outbreak and pandemic, people living with the NCDs are more vulnerable to becoming severely ill or dying from COVID-19, as we know. Despite so, the NCD care throughout the country has been disrupted due to the pandemic also in Indonesia. Slide. As we all know, the risk factors of the NCD are actually intercorrelating. For the example, lack of physical activity are well proven as the risk factors for the heart diseases, diabetes, stroke, and some cancers. Now, pandemic induces shifting of lifestyle, thus making impact on other risk factors as well. Slide. By the hit of pandemic, outpatient visits, including Indonesia, decreased to 60%, thus leaving the most urgent cases only managed in healthcare facilities. Of course, as NCDs were often prescribed with routine medications, the disease control were greatly influenced. Slide. This graph showed that younger children and elderly, as the population with the highest risk, were with the lowest visits. And also in my field in dementia care, several factors affected current overall rise of outpatient visits for the age group, clinician specialty, and also the insurance owned by the patients. Slide. And this graph showed approach that worldwide to overcome the disruption in NCD care throughout the pandemic era. The telemedicine and triaging case priorities were the most common approaches taken, especially in high-income countries. Also, we do in Indonesia. Indonesia, as the lower middle income country, also followed this approach. Slide. And those are the COVID impact on Indonesia citizen access of health, especially in NCD patients. The first is we know that there is an increasing of mortality and morbidity from COVID-19 infection, especially in NCD populations. The second is there is an increasing in mortality and self-quarantine of medical workers too. Hospital as one of the infection cluster and NCD patient, especially at the first phase of the pandemic, do not want to go to the hospital. That's their opinion. And the Indonesian citizen who travel to other countries for medical purpose cannot travel for a certain time. obstacles to obtain golden period to treatment of acute NCD2, such as a stroke, heart attack, we have the huge obstacles there. And also the ineffective on NCD's early detection program from the earlier program that we have mentioned from the post-window of the puskesmas. Slide. So that we do the approaches taken in Indonesia. The first is resolving the COVID-19 pandemic problems from all of the stakeholders, including the government and also the medical workers and all of the society there. The second is to advance care to provide Indonesian people who previously travel for medication and cooperation with outstanding healthcare provider. The third is we are doing the hospital setting of reducing risk of infection clusters such as shield ventilation, strict screening protocol, private emergency ward, intensive care, and in-ward. We do also the hospital protocol of reducing risk of infection clusters such as home visiting care, drive-through swab or vaccination, drive-through clinical care, telemedicine, and triaging priorities. We do also make some efforts in public participation-based intervention for early detection and management of NCD cases. Slide. As we do in the Mandaya Royal Hospital Group, we do the advanced care to serve Indonesian people who previously travel for medication. Our hospital try to provide with 3 top services in the Heart Vascular Center, Advanced Care Center, and in my field is brain, spine, and pain center. We do from the prevention, early detection, diagnostic center, and multidisciplinary treatment of those 3 advanced care. Slide. The advanced care to provide Indonesian people who previously travel for medication and cooperation with outstanding healthcare provider. In this term, the Mandaya Hospital Group has the MOU with the Royal Brompton Hospital and also the clinic hospital. And then we can, maybe if the patient cannot go overseas to seek the medical purposes, we can contact our partner in the Royal Brompton and Cleveland Clinic for assessing their problems. Slide. We do have the comfortable hospital setting for reducing risk of infection cluster. The Mandaya Rural Hospital Puri provide comfortable hospital, huge ventilation, strict screening protocol, and private emergency ward, intensive care, and in-ward in the hospital. Slide. We do also the home care. Slide. And drive-through clinic, so we can assess the patient when the patient doesn't want to enter the hospital. So such like in this picture, our doctor examining the patient in his car, and then we do also have the swab and vaccination through drive-through. Next, we also provide the telemedicine in our hospital, and I know that many of the big hospital in Indonesia also provide this telemedicine. And besides that, there are several also telemedicine provided by the applications like a commercial provider. Slide. We also know that the needs of public participation-based innovation for early detection and management of NCD cases through the pandemic era. That way, we invent some applications and social media and influencers to change the way of our communication. So previously in pre-pandemic, we do the promotion and prevention program using offline meeting, many held by the Pospindo and Puskesmas and health center, and also the hospital and etc. But in pandemic era, we are oftenly use the social media and influencers, and also the applications that is related for the detection. Slide. The Ministry of Health also do the social media communication, such like this movement of the healthy lifestyle of slide, and for the detection such as stroke, slide, diabetes of the complication, and also the cigarettes, slides. Smoking, I'm sorry, and then for the cancer detection signs. Slide. I myself also have innovation in do the slogan for the dementia screening, Lali Lulelo, which means the emotional ability. Linglung is for confusion, Lupa is for forgetfulness, Lemot is slow thinking and the decreasing of logic. Slide. This is also the slogan from my copyright, yeah, for the memory that is dangerous, yeah, or tend to be dementia. Slide. And we also do invention in the digital tools. Yeah, we know that this is also the key point in Indonesia, and we also elaborate with some strategic partnership to do the digital tools. Slide. As we know that in all of the global, in my field, there are some digital tools for the cognitive screening. And in Indonesia, we invent two application, which is e-memory screening and e-memory center, e-memory clinic. Sorry. Slide. This is the e-memory screening. Is one of our invention. Is provide three features there, and the first is scientific writings from neurologists. And we do the 88 in Indonesian version for the screening. And if the score of above 2, there are also GPS related for the patient to get the nearby doctor recommendations. Slide. And all of the we have the very good satisfaction score, below 8 points. And this is the copyright is to my name, and I give the copyright to the Perdosi or Indonesian Neurologist Association. Slide. And the second is the telemedicine in Indonesia. We know that there is some barriers here, and it is a strategy for the Indonesia because Indonesia has archipelagic countries, have ethical values during the pandemic. Sure, the telemedicine has these limitations, but the implication is not to harm the patient, especially failing to identify the potential red flags, manage medical secrets, independent medical committees that are professional and work hard for the credential and also the quality training, ethics discipline, ethical medical discipline audits. Because we should also preserve the education to the telemedicine in Indonesian physician, because Indonesian physician doesn't born in their curriculum to study or manage the cases through the telemedicine. Slide. This is my writings of the slides, please. Sorry. This is my writings of the telemedicine in Indonesian language. Yeah. Slide. And also in my role as the chairman of the Indonesian Medical Ethics Board, we also provide the regulation for the Indonesian telemedicine approach. Slide. This is the current regulation in Indonesia for the telemedicine. Slides. And there are many telemedicine tools in Indonesia, based on the health facility or from the platform, such as there are so many platform in Indonesia, more than 10 platforms. Slide. There is also application to make the health support group. So, and then slide. Maybe thank you for sharing our ideas for countering the NCD problems through the pandemic era from Indonesia. Thank you.
Okay, thank you very much, Doctor, for the presentation. We'll come to the Q&As at the very end of the session. So I think we're going a bit over time. So can we go straight to Professor Dr. Razman Jamin? So Professor, if you have the presentation, can you please go ahead. Thank you.
Thank you, Dr. Takeshi, for your kind introduction. My name is Dr. Razman. At the present moment, I'm the director of Hospital Chancellor Tuanku Muklis, which is one of the university hospital in the country. And I would like to share my experience of managing NCDs, especially in relation to the pre-COVID and also post-COVID situation. If we see that, I think in Malaysia, I think when we started the COVID declaration somewhere in March 2020, I think we were in a good shape, I would say, because I think it was under control and everyone was a bit worried about the situation of COVID. And obviously, I think all over the world, people were very concerned, and over time, people were happy that we were able to contain the disease. And I think and that's why we started to open up our activities and also our economic activities as well. But I'm sure you all had seen and had read what happened over time when I think the Malaysians have had a surge of COVID-19 somewhere early this year and eventually had basically disrupted the whole activities. But before I move on to discuss about that matters, and perhaps I would like to share with you what are our strategies actually in terms of the NCD prior to this COVID-19, and perhaps I will share how we plan to tackle these situations on that matter. Next slide, please. You can see that I think in all over the world, especially in Asian countries, these are the common problems that we are seeing with regard to the NCDs. You know, the diabetes, hypertension, high cholesterols are quite predominant in our country. And that has a major risk factor for the cardiovascular disease. And for the audience information, the present moment, cardiovascular disease is one of the common cause of death in our country. And I'm sure it is quite common in other countries as well. And if you can see that, I think beside those diabetes, hypertension, and cholesterols, also we do have problems. Although that I put here is just a mammogram screening, but actually we are looking at cancer problems, the situation. The cancer is on the rise. The reason being is perhaps, I think, more detection is being done over the years because of the improvement of technologies. More doctors in specialties that are able to do that. And perhaps our screening program, which has started a long time ago, had proven that it has shown that. Example, like in breast cancer, our mammogram screening are basically available in any government or private hospital in the country, and it's accessible for everyone. But over time, I think with the country going for developed country, and I think these are the few issues that started to come, like depressions among our adults. And I think these depressions or mental health is also affecting our children's over time. And I think that's very something that is concern. And eventually, I think one of another issues was regard our active lifestyle, which I think at the present moment, because of the stress of the work environment and economic impact, I think 1 in 4 are basically not an active person. Therefore, I think the Ministry of Health has started a national strategic plan for non-communicable disease starting for 2016 and 2025. Before this, we have a 5-year planning, but I think with regard to the new search of all this, they had put a 10-year planning, which include all the matters that I had mentioned. Next, please. And I think the other facts that I would like to share with you all is that with regards to the medical services or health services, majority of the services that have been provided are basically by our public facilities, which through the government hospitals, government health clinics, and also through the university hospitals. And this comprise nearly 65% of the health facilities available in the country. The rest are being taken care by the private facilities, especially in the big cities, and also big town. And if you look here, the distributions of the patients groups, B40 meaning that 40% below 40% of the population where their income are less than certain numbers, M40 a middle income group, and T20 a higher income group. And we can see here that basically the B40 groups do have a significant impacts on our public facilities because majority of them are basically financially unable. Therefore, I think they will use most of the public facilities. Next. And when you look for admissions, again, this correspond with the utilization of the facilities with regard to the hospitals. Again, those with a lower income group will predominantly utilize the government hospitals and as well as the middle income groups. Some of the middle income group were able to use the private hospital facilities because of the insurance coverage. And for your information, at the present moment in our country, that we are there is no regulation for everyone must have medical insurance. There is no national insurance policy yet, so it's an individual capacities. But I think with regards to the higher income group, that I think financially able, that's why they will prefer to use the private hospital services and everything. Next slide, please. Come COVID, I think as we are well aware, I think the last year, Malaysia had quite well controlled in terms of the COVID infections. And I think we had, when we started in March, we do what we call a movement restricted order in the whole country. Basically, it's a total lockdown for the country for nearly 6 months. When we realized that we had under control, and somewhere in September where we started open up again, and this involved economic activities and other activities as well. During the last 6 months, between March until September, basically Malaysians were at standstill. We were not able to do a lot of activities. Then I think the one that being allowed to start traveling, going into open spaces, were only the frontliners or medical team, and as well as the personnel from that require what we call basic requirements. But otherwise, most of our population have to stand still, and even the school and everything has been closed. These are quite significant for total lockdown. But eventually, I think what happened starting in November, then we can see the rise of the cases, especially in our country. And I think the peak of everything was somewhere in July to August. That's why I think the chaotic of our service, and that's really tested our medical facilities. And for your information, especially in Klang Valley, or what we call a central Kuala Lumpur, that I think there were overwhelming cases that we were not able to handle some of the cases. Our hospital were selected as hybrid hospital, where we took care of the COVID cases as well as the non-COVID. But I think over time, the first in 2020, we were not able to open the service. Basically, 6 months total shutdown of the clinics and everything, because I think we were focusing on the COVID as well. We only running 20% of our capacity for the NCDs, basically the outpatient and clinic. But when we started somewhere in February, and we started to open up our services slowly, but until now, despite I think we had a good control of the COVID because of the vaccination programs. I think nearly 95% or 99% of our adults had been vaccinated up to 2 doses. We started to open up, but still a bit cautious. Now we're only running about 50% of our capacities in most of the public hospitals, because the reason being, you know, before COVID, there were overwhelming admissions, overwhelming clinic attendance, but we realized that most of our hospitals were congested. But by having this COVID, we were able to control much better. Then, therefore, I think the ratios of the clinics that had to open up mainly 50 to 60% of the original capacity prior to the COVID. So that also put us on alert, because I think the impact on February had teach us, especially in our country, that I think despite whatever facilities that we have, good facilities in our country, when we come a chaotic, I would say, emergency like this, suddenly we were caught. And then although that a bit controlled, but still we learned that we need to develop more. That's probably part of the future that we are developing. But let's go for the NCD. What happened now? Next slide, please. I think, next slide, please. I think with regards to the strategies for continuum care of NCD, yes, we had started to open up our facilities. I think during for the nearly 1.5 years, even until now, we were not able to open our theaters for our patient, especially cancer patient, because of these issues. Now we only cater, only 30 or 40% of the hospital can only open their theater services and cater for only for priority or critical cases, inclusive of cancer. Therefore, the elective cases like gallstones, hernias, can't be done because of the limitation of that. That is severely affected. What we are facing now, I think, with the recovery plan that we have put up following the post-COVID, we need to optimize our emergency services, because there were overwhelming cases, especially after the post-COVID, and the NCD cases that come, they come with complications. Either diabetic-related complication, IHD-related complications. Therefore, I think we had to optimize our emergency services, because sometimes we even have to close our ED because of the over-admission through the ED, and we are not able to mobilize the patient accordingly. Our critical care also at risk because now, although that example in my center, we have 40 beds, but we have reserved 20 beds for COVID patients that require ICU care. So can you imagine that before COVID, 40 beds for ICU for critical care, but now with the same numbers of the patient volumes, we only have 50% less of our ICU care. We have started to open up our other health facilities, our clinics, our wards, but we had followed the standardized SOP that have been introduced by the Ministry of Health. And we also had introduced our own standard operating procedures. Example, like I think if this patient require admission, they must have their PCR to test their COVID being tested prior for admission in order to reduce the risk of infection within the facilities. We had a few examples or a few experiences where if the ward had been infected, that create a very chaotic situation. Other strategies that I think the government had performed during the COVID phase and also the post-COVID phase, if you've seen that the private hospital has been underutilized at a certain extent, therefore, we had what we call a decanting of the public patient to the private facilities, and the cost of the medical bill has been borne by the government. I think that's a very good initiative because most of the private facilities does not take care COVID patient, and even they take care, they only take care about 5%. The rest are all non-COVID. Therefore, there's the strategies that government have put that they decant the patients to the private facilities, especially for the cancer cases and other urgent cases. With regards to the utilization of new technologies, yes, teleconsultation has been initiated, and I think some of the hospitals have started. We have started our teleconsultation, but I agree with the previous speaker that there are a lot of issues that need to be addressed, especially with regards to the legal issues, risk of the medicals patients, and selection of the services. So we had completed our requirements, and therefore we should be able to use that. And in our hospital, our strategy is probably about 30% of our patients should utilize teleconsultations. And what about preventive programs? We have started enhancing webinar activities. A lot of doctors, although despite the COVID, have started actively using, I would say, multimedia platform for promoting the health. And I think there's a good positive cultures that we are in. And the other matters is with regards to the digitalization of medical services, not only teleconsultation, but also other matters to basically improve our services and therefore reduce the care of COVID impact, but yet improve of the NCD management. Examples of the optimization of medicine delivery also have been implemented at our centers, like I would say Grab or Uberizations of the medicines to our patients, therefore they don't have to come to the hospitals. And the other important engagement that we had acknowledged is regards to the involvement of our NGOs and also societies and media for health promotion. I think that's very important. And I think over the last 2 years during this period of COVID, the NGOs and societies has contributed significantly, not only to our hospital, but also to other services. Next. These are the examples of how we utilize the media, although these are physical medias, but also our social media have been fully utilized. And I think the preventions of the medicines, preventive care and everything, we are using these approaches. Next, please. So in summary, I think we agreed COVID-19 has severely affected the NCD management and health facilities in Malaysia, but I'm sure it's not only in our country, but it also affected the whole world. And I think, to me, in our opinion, continuum care of NCD require more holistic approach, because I think end of the day, these are major stakeholders, a major component of our health services, and eventually the impacts of the economy will be affected as well. Therefore, I think the whole party had to get involved. Engagement of other health facilities, NGO is necessary, and I think they are paramount for effective delivery of NCD cares and also prevention. And I do agree the utilization of new technologies and multimedia for effective delivery of care, especially on NCD management, because this is something that basically easily accessible. With that, Mr. Takashi, I would like to say thank you very much.
Thank you very much, Professor, for the very interesting presentation. And I see we do have some questions piling up in the chat, which we will come back to at the very end of the session. So anyway, thank you very much, Professor. It's a very good, interesting presentation. So again, I would like to quickly go on to the next presenter, who is Dr. Sunil Bhudia of the Royal Brompton Harefoot Hospital in the UK. Dr. Bhudia is a cardiac surgeon, and he will be talking to us today about a very innovative and collaborating approach to handling cardiac surgery, cardiac patients in the London area. So over to you, Dr. Bhudia.
Thank you, Dr. Takashi, and thank you for the invite. Can I have the slides and then I can start talking, because I think we're running a bit behind time. Introductions have been made, and I'm going to talk to you about what we did in London during the pandemic. Next slide, please. And mainly, I want to emphasize on the collaboration and innovation. As you may be aware that in UK, we have a nationalized health service. Majority, in fact, over 95% of our patients use the National Health Service, and it is obviously comes from the tax. So we entered a new world last year in March, as we've all been discussing, and we had edict from the government, and obviously we went into lockdown. We had to reconfigure services, and we had to reassign the duties that various people had within the hospital to help out with the pandemic and the other services. Next slide, please. And in cardiac surgery, next slide, we had to collaborate with the other hospitals and within the hospitals. So, for example, if I wasn't doing anything, then I would go and help out in the with the COVID patients. We started collaborating across London, which I'll talk to you about in a little bit more detail. Of course, we collaborated across UK because it's a national health service. And also we were learning and also teaching the rest of the world as to what we were learning, what we were experiencing, because what happened in China and Italy was not true for us in the UK. And we started discovering new problems with the COVID. But the aim of this is not COVID, but how we dealt with the NCDs. So obviously we had to come up with innovative ways of monitoring our patients, undertaking meetings, because we have lots of multidisciplinary team meetings, and also how we were going to undertake our clinics. Next slide, please. And when it comes to collaboration, next slide, within the hospital, we started breaking down barriers. Next slide, please. We broke down the barriers, and we were working cross specialties. So as a cardiac surgeon, I would go to the intensive care unit, and I would help out in the intensive care unit. We, of course, collaborated in across London. I'll talk to you a little bit more with that in a bit, and also UK and the world, because in London we had the first wave, and we felt the effect before the rest of UK, and obviously we were teaching rest of the UK of how to reconfigure the services. Next slide, please. And this is a map of Greater London, and there are 7 cardiac centers in London, and the ones in green, Harefield and St. Bartholomew, so Bart's Hospital, we were dedicated to be the cardiac center. So we were supposed to be looking after the cardiac surgery patients across the whole of London, which is a population of about 9 million. And the other 5 hospitals were asked to shut down the cardiac services and concentrate on other aspects of various. So, for example, Hammersmith were dealing with renal failure patients. So between the 2 hospitals, we invited the rest of the surgeons from other hospitals, staff from the other hospitals, to collaborate and deliver cardiac surgery across London. Next slide, please. And immediately we had to start thinking about our patients in cardiac surgery patients. Because we have a long waiting list for all the patients, we had to categorize these patients, because a patient we may have seen 3 months ago may be a bit more acute than a patient we saw yesterday, and vice versa as well. So we had to categorize all these patients very quickly as to which category they would fall into. So if you go to the next slide, that will become a bit more clearer. So we had to categorize them from 1A to 4. 1A is very clear it's an emergency operation. So we like acute dissection, we just get them in and operate on them. And then of course we had to categorize mainly the patients who were at home into 2, 3, and 4. And everyone had to start categorizing their patients and then assessing which of these patients required surgery in a timely manner. Next slide, please. And of course, then we undertook these procedures across London between the 2 hospitals. Next slide, please. And next slide. And next slide. And what we thought is how we are going to monitor our patients. We started looking at app-based. So we had various applications that were available, and we straight away adapted one of them so that the patients could download this onto their mobile phones, and they could tell us about their symptoms. So once they would the category we had already categorized these patients, if they were worsening on the app, then we would contact them, and we will then upgrade their category for surgery and bring them in as a matter of urgency for their surgery. Of course, we also went into a virtual multidisciplinary team meetings, and compared to Malaysia and Indonesia, some of this technology was already available to us, but we had not adopted it widely. So this was an opportunity for us to start utilizing this technology. So for the virtual MDTs, we started using Microsoft Teams, and now it is widely used. The slides have gone away. If the slides can come back again. I'll carry on talking. And the Microsoft Teams was utilized. And then for virtual clinics, again, this is quite interesting. Before the pandemic, we wanted to introduce some virtual clinics so patients don't have to travel to us, and we can assess them from home. But the uptake for this wasn't very good. But during the pandemic, obviously, that accelerated this process. And now we do most of our clinics virtually. But I'm a surgeon, so I may want to see my patients before I operate on them. So some of these patients do come in face to face. Next slide, please. So obviously we started collaborating, and obviously innovation was the key, and mainly we want to see how best we could treat our patients. Next slide, please. And now what we are finding, now this is moving on from, because we've gone through the 3rd wave, now we are moving on. In our hospital at the moment, we have very few, hardly any COVID patients, but we are trying to increase our throughput. At the moment, most of the days we are doing more than 100% of what we are doing before cardiac surgeon. We've managed to achieve that through collaboration and innovation. So all the 7 centers are now operating. Some of them are not back to full capacity, but we are increasing our capacity. And you can see Greater London, we get patients from all across us. On the left-hand corner, we get patients from all the way from Wales. That is a long distance away, considering that they go across 2 other cardiac centers to come to us. But also we have expertise in transplantation and heart failure. So that's the other reason why they come to us. Next slide, please. And if you look at the population, as I mentioned before, so we had a census last year, and as of last year, the population of London, so this is showing us population of London is just over 8 million. But what is interesting is that during the nighttime and during the daytime, the population is markedly different. During the daytime, there are 20% more people in London than they are at nighttime. So you can imagine how we have to keep fluctuating our services between the centers to accommodate for this fluctuation in the population. So that's something that we've started to work on, and obviously the virtual clinics and virtual MDTs is helping us to do that. Next slide, please. And if you are to compare our London population, which is, as I said, just between 8 and 9 million, and you can see Jakarta is not far off and Kuala Lumpur is not far off. So, but if you look at the number of cardiac centers you have in Jakarta and Kuala Lumpur are much less than we have in London. So clearly, I know cardiac surgery is not top on the agenda. There are lots of other reasons why patients suffer in Indonesia and Malaysia, but the last presentation did show that cardiovascular disease is quite important in Kuala Lumpur as well. Next slide, please. So what's happening with us moving forward? There's something that we call Cardiac Pathways Improvement Program, which is a countrywide program, but we've started that in London and in England. So as you know, UK is divided into various regions. In England, there are 6.4 million who are affected by cardiovascular disease, and this is going to have a bigger impact. And obviously, COVID hasn't helped us. There are people who have not come out to see their doctors. So we are finding that when we are seeing them in hospital, that they are at a much advanced stage. So they may be having heart failure symptoms, whereas they may not have had that before. And obviously our waiting lists are increasing, or they're the same. And that's a worry because we have a finite way of dealing with our patients, finite resources. So we need to find new ways of working and collaborating in order to service our patients. Next slide, please. And for us, what is key is data. This is again telling us what are the priorities in this Cardiac Pathways Improvement Program. And this is something that has started this year, and it is something quite innovative as well. Next slide, please. And so this is an example of what's happening in South London, whereby patients are referred into a central hub, and all this is done virtually, and those patients are then directed to the right hospital in a timely manner. So again, this has come on. Some of this work had started pre-pandemic, but the pandemic has helped us to accelerate this process, and this is some work in progress, and we are benefiting from that, and our patients are benefiting from that. Next slide, please. And what is key is obviously the data that we collect. We collect loads of data, but up until now, we never utilized that data in the right manner. But now we have something called the model health system. So you can think of what would you want if you are a patient, and what sort of service would you like if you are a patient. So this is the model health system. You can go in, so there are ideas on that, and you can punch in your hospital and see where you fall within that model health system. So again, this is data is helping us to come up with innovative ways of getting the patients through our hospital, not only cardiac surgery for cardiac patients, but all the patients who come into the hospital. Next slide, please. And next slide also shows about how in London we have used the model in cardiothoracic surgery, we've used the model health system to improve the services that we provide to the patient. And also we can look at the costing and how we can reduce the cost, because why should there be a variability in costing for the same procedure in London across the 7 centers? So this is a system to help us sort of equate the cost for patients. Next slide, please. And I'll go through the next few slides fairly quickly. Again, this is just emphasizing the fact that we've got lots of data, and now we are getting a bit more intelligent at utilizing our data. So these are the cardiac surgery waiting lists, and you can see waiting lists. We started collecting this data in April, combined data in April of last year. Data was collected, but not as a combined data. And now pan-London, we do collect this data, and you can see that the waiting list did go up, and now thankfully they're starting to come down because we are opening up our services across the 7 centers. Next slide, please. And this again reiterates the same message, but this is again looking at the various categories. You know, we had to categorize our patients from P2 all the way to P4, and you can find that, and you can see that the number of P2s, those are the patients who need surgery within 28 days. That number is slowly coming down, and which is encouraging. Next slide, please. And finally, who benefits from all this? I think the patients are the biggest beneficiaries from this collaboration and innovation. Our health system will benefit because we are becoming more efficient, and wastage is going to get less. And then finally, because we are a public funded system, the National Health Service, obviously the public is going to benefit as well, that our taxes will not go up. We will have efficient systems, and people are talking to each other. We never used to talk to each other before, and that's quite strange. Now there's lots of collaboration, lots of innovation, and within our hospital, even for patients who have, when they go home for their surgical wound, they don't have to come back to hospital to show us their wound. We have an app whereby they can take a picture and send that app, and that again is recorded on our electronic patient records. So this is an example. There are lots of examples we can talk about it, but in view of time, I'm going to. I think that's all what I'm going to say. And next slide, please. And thank you very much for your attention and for the opportunity.
Thank you very much, Doctor, for the presentation. I see we have a few questions coming in, but we'll go to those at the end. So in the interest of time, we're still a bit behind schedule. I'd like to go to the next presenter, who is Sandra Komazinski, a data scientist at Aparito, and we'll shift gears a little bit and then focus on the new technologies which are emerging for the treatment of medical care of NCDs. So, okay, so let's go. Sandra, can you start the presentation?
Yeah, sure. Thanks very much. Hello, everybody. So I'm Sandra Komazinski, data scientist at Aparito. Can I have the next slides, please? Yeah, so I'll give you first a short introduction to Aparito and then move on to three case studies to present remote monitoring. So the first one would be in cancer, and there will be two long COVID studies. Next slide, please. So Aparito is a 7-year-old UK-based company providing mobile health and patient-centric remote monitoring solutions for clinical trials, and we are focused on rare diseases. Our digital platform called Atom5, associated with specialist clinical and regulatory knowledge, can support the remote monitoring of patients outside of the hospital. So we can capture data through our pattern recognition tools, but also video analytics and customizable app. Indeed, our Atom5 platform is highly configurable, so it is disease and language agnostic, and it includes an app for customized assessments, but also a video capture capabilities and wearables integration. Next slide, please. So I'm going to talk through how empowering patients using a decentralized approach can ensure clinical trials can be conducted in the COVID era. And I'll start by reviewing a study we performed with oncology patient. Next slide, please. So many challenges emerged with the COVID pandemic and impacted the conduct of clinical trials globally. So the pandemic left many patients feeling anxious with little control over if, when, or how they will receive a diagnosis or treatment. Many patients did not go to the hospital even when they had symptoms because they were afraid of catching COVID-19, and other patients were unable to keep appointments because clinics and wards were closed, and they could not travel due to lockdown. So for patients who were able to get to the hospital, being unable to take family with them or to help ask questions or understand treatments options put them at a disadvantage in planning care and making informed decisions. With the pandemic, many of the methods previously used in clinical trials were no longer practical when people had to remain at home and could not travel to study sites. So patients' recruitment in most cases had to be put on hold, and an estimated 70% of clinical trials worldwide have been affected by the pandemic due to the patients' recruitment being postponed. Next slide, please. So in response to the pandemic, we deployed our platform paired with a wearable device in a local hospital in North Wales. So the patients were given a wearable device, which was connected to the specific study app. Through the app, patients reported COVID symptoms on a daily basis, but and a notification was sent to the patient when a questionnaire were to complete. Patients could also manually enter other measures like temperature, heart rate, or blood pressure. And the data that were captured passively by the wearable were step count, motion, heart rate, but also nighttime oxygen saturations. So the clinician dashboard allowed clinicians to review the data in real time. So this study aimed at demonstrating the feasibility of a remote monitoring of cancer outpatients during the pandemic, but also aimed at evaluating the quality of the data collected and what insight into the disease and day-to-day quality of life can be retrieved from the data. So the hospital in North Wales, where the study was deployed, covers a large and dispersed area where there is extremely limited public transport links, meaning that patients could travel for an average of 1 hour and a half to attend an appointment. So this area in particular, where assessing the hospital can be inconvenient, can benefit from a decentralized clinical trials, which eliminates the need for travel. Cancer patients that were under treatment or surveillance were invited by the clinical team during routine appointments, which were mostly conducted over the phone at the time. So we started the study at the beginning of the pandemic in April 2020, or they were invited via the North Wales Cancer Patients Forum group. Next slide, please. So in terms of data that the patients produced, so we had 49 patients that produced data. The mean age of the patients was 65. There were a total of 2,800 patient days that were reported or collected by the patients. And we had a median number of days with data of 56 days, sorry. We had a patient's engagement with the remote technology that was clearly impressive. So median engagement with the wearable device was 89%, and the engagement with engaging with the app for completing daily symptoms was just above 70%. And if we look at the graph, we can see that half of the patients collected data for more than 8 weeks, and even the majority of them collected data for more than 12 weeks. And the other half collected data for just less than 8 weeks. Next slide, please. So patients reported each day which symptoms they were experiencing. And it was for this particular study, they were asked about specific COVID-19 symptoms, but in fact, the most common reported symptoms were the usual symptoms experienced by oncology patients as adverse events of their treatment, like, for example, body aches, appetite loss, or fatigue. And the longitudinal report of symptoms can offer insight into patients' profile over time, from which we can identify signs of deterioration of improvement, like shown here with the reported well-being over time. And using a home-based symptoms reporting, patients can report actually their signs and symptoms earlier than waiting for their next clinical visit, which facilitate a more efficient and effective symptoms management and give the clinician a view over time rather than single snapshots over the patient's symptoms. Next slide, please. So the data collected with the wearable device offer continuous monitoring, which can allow for identification of changes over time. And on the left-hand side, I've put an example of step count by hour for one patient. Here, a darker color indicates higher step count. And we can see on the graph that there is a peak in activity between 6 and 7 a.m., but also that the patient is slightly active in the afternoon. But we can also observe changes over time if you look at the vertical axis, which represent the study days. We can see that step count during the morning peak were higher during the first days than toward the end of the monitoring period. But longitudinal observation over a long period of time can also identify trends and patterns, like the upward trend here in resting heart rate as an example. Next slide, please. So some findings. So we shown that the remote monitoring and a decentralized approach allowed for a rapid deployment and rapid enrollment. Actually, all the patients were recruited in a 2 weeks time. And it also allowed for the study to take place when so many were suspended or delayed. The study also demonstrating the feasibility of remote monitoring of our cancer outpatients during the pandemic. It allows the clinician to observe their patients outside of the clinic and patients to take control over their health. There was a high data capture that was achieved and a good data quality, which allowed for insightful analysis to be performed, which can inform on near real time on the patient health. So the data analysis is still ongoing, but we published the results and our experience of the feasibility study in the Journal of Clinical Oncology, Clinical Cancer Informatics earlier this year. Next slide, please. So I move now to another study, which is an ongoing study. So this is a large randomized platform trials of therapies aiming at improving long-term outcomes in patients with COVID-19 post-hospital discharge. So around 1 in 10 people with COVID-19 continue to experience symptoms and impaired quality of life beyond 12 weeks, which is known as long COVID. Next slide, please. So the study named IL-COVID was established in early 2021. So when the trial began, there were no treatments established in randomized clinical trials targeting the longer term or convalescent phase of the disease. So IL-COVID is an adaptive platform trial design to provide reliable evidence of the efficacy of post-hospitalization treatments aiming to improve clinical outcomes from COVID-19. Next slide, please. So the primary objective of the trial is to determine whether interventions in the convalescent phase of COVID-19 improve longer-term mortality and morbidity outcomes. And the secondary objectives are to determine and evaluate treatment-specific and patient-reported outcomes of COVID-19 and their response to intervention, and to estimate the cost-effectiveness of treatments. Next slide, please. So the study is recruiting hospitalized adult patients recovering from confirmed COVID-19 and approaching the end of their admission. So with an estimated planned discharge at any time point within the next 5 days. Next slide, please. So this is a multi-center platform study that will evaluate up to three arms against the usual standard of care. Next slide, please. So a set of patients reported outcome have been selected for the study, and they assess fatigue, but also post-traumatic stress disorder, quality of life, intervention tolerability, but also additional disease-specific symptoms. Next slide, please. So the patient's reported outcomes are administered using the ATOM5 app. So patients receive notifications when PROs are to be completed. And you can see here a patient app. So basically, everything in orange indicates a task to be done, and patients can click on the questionnaire that needs to be completed and just complete it and submit. And the clinical team then have the answers in real time on their dashboard. Next slide, please. So a randomized control trial, so a study within a trial, is embedded with within ILCOVID to look at the impact of questionnaire frequency on questionnaire completion. So patients are randomized to receive questionnaires at different frequency. For example, SWAT1, they will receive the questionnaire weekly for 4 weeks, then receive them monthly. For SWAT2, they'll complete the questionnaire weekly for 12 weeks and then monthly. Next slide, please. Yeah, so this was a short introduction to the ILCOVID trial, and the patient's recruitment is still ongoing. So far, there were more than 700 patients recruited. Next slide, please. So I'll present you now another long COVID study, which is done in collaboration with the University of Birmingham-led team, which will identify and recruit 2,000 of non-hospitalized patients with long COVID who have had symptoms for 12 weeks or longer. Next slide, please. So the researcher will aim to co-produce with patients a targeting intervention for long COVID, which is tailored to individual patient need. Because it is delivered remotely in the community via an app, it will provide critical information and support to empower patients in self-managing their long COVID. In addition, the researchers will provide tailored resources to support symptoms management and nurse-led support for those with the severe symptom. Next slide, please. In this study, the researcher will review evidence for long COVID treatments, including drugs or supportive interventions, like, for example, for mental health or fatigue. And working with patients, doctors, and other experts, the researcher will recommend treatments that should be tested in long COVID patients and then co-produce a targeted intervention for long COVID, which is tailored to individual patients. So there will be the use of the ATOM5 platform, which is configured for the study by experts from the University of Birmingham with patient input. Participating patients will be given access to the platform, allowing them to self-report symptoms, quality of life, and work capability. The researcher will use the platform alongside biological and immunological data in a subgroup of patients to assess whether the treatments and supportive intervention reduce symptoms, but also improve quality of life and are good value for money. And all data gathered will be used to help the scientists characterize the symptoms, health impacts, and underlying cause of long COVID symptoms in non-hospitalized patients, which will provide insight into which is not currently available. Next slide, please. Because of interest of time, I think I'll just skip this slide. So next slide, please. So because the existing measures do not fully capture the symptoms of long COVID, a symptom burden questionnaire has been developed for the study, which is measuring long COVID symptoms and how those symptoms affect people in their daily life. So the questionnaire addresses multiple domains like breathing, pain, fatigue, mental health, ear and nose syndromes, symptoms, sorry, and it also asks patients to describe how their symptoms affect their daily life. So the questionnaire is delivered using the Atom 5 app, using a mobile phone, and it is available to complete at predetermined intervals or ad hoc. It will allow for remote monitoring alerts to be sent to the clinician team to inform on changes in symptoms. And for the researchers, it will be a new tool for assessing the effectiveness of new treatments and therapies for long COVID. Next slide, please. So the team worked closely with national UK long COVID support groups to develop the application and ensure it is acceptable but also usable and relevant to the patients. And you can see here an example of how the symptoms burden questionnaire is implemented into the app. Next slide, please. So I hope it gave you, this presentation gave you an overview of the study and how what is done to best support people who have these long-lasting symptoms. So the study recruited patients to test and develop the symptoms burden questionnaire, but we'll start next week our recruitment for the next phase of the study. Next slide, please. I'd like to thank you for your attention and for the opportunity to present today. Thank you.
Thank you very much, Sandra, for the presentation. So we're really late on time. So let's go straight into the next presenter, Dr. Wake of My Way Digital Health. So let's go straight into the presentation. We'll be exceeding our time limit, but don't worry, Debbie will make sure that you have your 15 minutes. So no need to hurry there.
Great, many thanks. Hopefully you can see my slides. Thanks so much for the opportunity to present today. I'll go through these quickly and try to get us close to back on time. So my background is I'm an endocrinologist, diabetologist based in Scotland. We've developed a system that we've rolled out nationally in Scotland over the last 15 years, and we're now starting to take that solution throughout the UK and internationally, including a project that we're about to start in Malaysia in January. So I'd like to just share some background around that. The focus has been around diabetes, but what I've shown you and the data-driven support systems is very much applicable across wider chronic diseases, and indeed we are now looking at how we expand this model into other long-term conditions. So we all know diabetes is a huge problem. About 10% of the world has diabetes, and our focus has really been on driving down the complications, which constitute about 80% of the cost of treating the condition. This is things like heart attacks, amputations, strokes, and so on. And in Scotland, we've taken a data-driven approach where we have a single national platform that manages every patient with diabetes from the day that they're diagnosed. We collate all the data on the patients from primary care, secondary care, laboratory systems, national screening programs, and we have a single IT platform for all clinicians to use. This is also used for national and regional reporting and research. And we make all the data in the platform available to patients through a system called My Diabetes My Way. People can register to access their health record online. They can contribute data to the system through remote monitoring devices, and they have access to a full education platform to support them remotely in management of their condition. So in Scotland, we have about 350,000 people with diabetes. And we've had around 500,000 people from Scotland and beyond access the platform for educational purposes over the last 10 years. People with diabetes have been disproportionately affected during COVID. In the first wave of the pandemic, 26% of all COVID deaths were in people with diabetes. And we know that those who have high blood sugar levels, higher weight, lower socioeconomic status, and from certain ethnic minority groups were at significantly higher risk of poor outcomes. As the pandemic has continued, we've seen a deterioration in all the routine care processes associated with diabetes and the treatment targets. So on the background of this, there has really been no better time to be really pushing forward with our IT digital solutions to use data to better support people with diabetes. And this is using data right from the point of self-management, right through to clinician decision support and population analytics to help us triage and risk predict. So we have two key platforms. Having built success in Scotland through a system developed by the University of Dundee, we spun out a company, and it's through that company, My Way Digital Health, that we're now taking these solutions to the rest of the world. And we have a patient and a clinician-facing platform that collates data from any electronic medical health record, home data, and we upload patient-recorded data. The patient system allows people to access key data for diabetes. It's color-coded according to international targets. It includes alerts and risk prediction, so that which can be outputted through the platform or through text messaging or email to alert people when tests are overdue or when they're out of range. It then uses rules, algorithms, and increasingly machine learning artificial intelligence to deliver highly tailored automated advice back to people with diabetes. And they tell us people with diabetes tell us it's when they see their data and start to understand the narrative that they really get control of their diabetes. Here you can see an example of long-term blood sugar changing over time. We encourage people to stay in the green. We invite them to set goals and to upload data themselves. But the system will develop a highly personalized narrative, linking them back to tailored information that is suitable for them. And this narrative changes depending on the person's personal data profile. Our system's the top performing diabetes app within the UK, and the data side of things links into educational courses. So we have 10 educational courses for people with diabetes, ranging from those at risk of type 2 diabetes through to those who've developed type 2, for people with gestational diabetes, and several courses for people with type 1 diabetes. We also have culturalized and translated a lot of our content. We're now doing a lot of work in the Middle East, in India, in the US, and about to start a project in Malaysia. But even within the UK, we have a highly diverse population. Our platforms run across places like Northwest London, where there's significant ethnic diversity. So this is important in terms of translating our courses. And one of the other things we did during the pandemic and continue to do is run completely free open courses for anyone throughout the world so that we can support them in diabetes management. And we've run these courses for both type 1 and type 2 diabetes. They run over 2 days. They're online. Anyone can join. And we will do things like live Facebook streaming to bring people through, as well as getting them to complete modules through e-learning. And we've had thousands of people educated through this. In one case, we had 20,000 people join a course over 2 days to be educated in diabetes. It's a highly efficient way to deliver education, particularly during a pandemic, when we can't get people together to deliver traditional face-to-face education. The data-driven aspects carry on through to clinician-facing systems. And as mentioned, in Scotland, we have a national clinician platform for diabetes, and we're now rolling this out across the rest of the UK and beyond. It supports clinicians to better manage the condition through giving them decision support. So again, using personal data to drive detailed, tailored messaging to advise clinicians when screening tests are overdue, when certain drug therapies should be described, and also including risk prediction. We have over 70 machine learning models predicting pretty much every complication of diabetes, from acute low blood sugar events and ketoacidosis and hospitalization, right through to predictions of cardiovascular disease, amputation, stroke, blindness, and so on. And it becomes very easy for the clinician then to look at who are their highest risk patients and to focus on the areas of care that need most attention. Our platforms also support complication screening, so screening for early signs of foot problems and eye problems, and again will risk predict future events. And this again will drive down complications through early interventions. And increasingly during the pandemic, we've been delivering our care remotely, either through telephone or through remote platforms. And our IT allows exchange of data and communication between patients and clinicians. It allows patients to upload data from things like Fitbits and glucose meters at home, and for clinicians to respond to that. But it also gives patients directly automated feedback on any data that they upload. At a population level, we can start to look at how a whole diabetes population looks, and this may be across a whole country. It could be across a region, across a hospital, or a single general practice clinic. And we can risk stratify and show people how they're performing against the key national targets for diabetes, and indeed risk predict the population. So during COVID, there's a big care backlog. We need to prioritise and triage which patients we're going to see. And again, we can risk stratify for different complications and start to then bring down lists of patients who are at high risk of certain complications to ensure that they are seen as a priority. So what I've shown you is a data-driven approach going right from patient self-management to clinician decision support through to population analytics and triage. And this has been our approach to managing and supporting diabetes care, both pre-pandemic, but increasingly this is becoming more important during this COVID era. And what I think is unique about the system is that it has data at its heart, but it can also be scaled very easily and cost effectively. So because we use data, there is very limited human resource required to deliver this service. So we can scale it for around £1 per patient per year based on whole populations. And we've been able to show a really significant cost saving with a return on investment of about 5 to 1 through the data-driven approaches. And we now have outcome data for over 10 years from the work that we've done in Scotland. But as mentioned, we're now scaling these platforms into many other regions. And so having shown that this works very effectively for diabetes, we're now using the same approaches to start to scale into other long-term conditions, including looking at people at risk of diabetes and other lifestyle diseases. And we've taken our Scotland approaches into the whole of the UK. We now cover about 30–40% of the UK and beyond. And in the final slides, I'd just like to share with you some work that we're now embarking on in Malaysia. So this is a programme that we've been working on for about 2 years with multiple partners. And these are some of the partners here that I won't go through in detail, but it's a collaboration with the University of Dundee in the UK, but multiple partners, including BMZ Technologies and Sesame in Malaysia and the National Diabetes Institute. And we're starting to look at how we can take a similar approach in Malaysia to one that's worked effectively in the UK. But it starts off with a health screening platform. So the Malaysian partners have developed basically a screening platform that supports screening for multiple long-term conditions, not just diabetes, and allows people to become aware of their health status and more proactive in managing that. And they've done this through basically a screening app and a screening platform that links into multiple downstream screening centres, both established centres and new screening clinics that have been set up by the local partners. It allows people to remotely book and at their own convenience, turn up for screening, have the test done immediately and get results back within hours, and then start to receive proactive follow-up and messaging through access to platforms like ours, which will support them in better self-management of their condition. So from a patient point of view, it becomes very simple to book a test online, get the test done in a few minutes, get the results back within hours, and then, as I say, link into long-term condition management solutions. And this is being worked up both through private clinics, but also through work with the Ministry of Health to see whether this can be also linked in with Ministry of Health clinics, and our clinician system also embedded within a number of primary and secondary care centres to support the long-term management from the clinician end. So in terms of the tests that are being done, diabetes is one of them, but as you can see, this is about screening across multiple long-term conditions. And as we continue to grow our service, we will be focusing on self-management aspects across conditions wider than diabetes. And obviously there's also COVID screening and things linked in with that as well. So that's just a very quick summary of, as I say, the backdrop in Scotland, the work that we are starting to do in Malaysia to bring some of these approaches forward, and very happy to answer questions. Many thanks.
You're still on mute, Takeshi.
Sorry, I was on mute. Right. Thank you very much for the presentation, Debbie. So actually, we run out of time, but I would ask the organizers to give us another 10 minutes so that we can answer address some of the questions, at least the ones which have come into the Q&A box, which I see there are 2. And for the other questions which come up, and I also have some questions which were received prior to the meeting by email, I will talk to the organizers and make sure that they will be answered in some form later on. And also keep the questions coming, because all the questions I will try to send out some answers in some way or another after the meeting. I do apologize for the poor time management on my side, but another thing I've learned is that I think the time slots were far too short to do justice for the very rich content that we saw today. So my apologies for that, and we'll do better at the next webinar, which I'm sure will be coming up quite soon. So with that, let's go to the Q&As. I see two in the box from Dr. Addy, both from Dr. Addy. The first one is, what has been the impact of lockdowns worldwide on skin cancer presentations in various countries? So can I break that question down to one to Dr. Pukavisa for how the situation has been in Indonesia, and then to Professor Dato for how that has been in Malaysia. So if you can give us some quick observations on this question.
Yeah, thank you, Mr. Takeshi. So the situation in Indonesia is right now the COVID-19 is under control. I appreciate all of the stakeholders that do the much effort to do this, especially the government and also all of the Satgas or the task force that is included, the army there, the policemen, and etc. to embrace the COVID-19 pandemic in Indonesia.
Yeah. But how about specifically for cancer presentation? Do you see less people coming to take the cancer screening tests? Do you have any statistics on that?
I do not observe very well, because it is not my field yet to do that. So, but the visits of the NCD's cases still the same. Yes, I think still the same.
Yeah. So I understand, and I think that probably is the case, because I do know definitely in Japan, the number of people who have shown up for cancer screening, which is done regularly, has decreased by about 10 to 20%. Over the last year, this year and the last year too. So there is a concern here that this will in turn translate to increased number of cancer patients who were not diagnosed at an early stage. And that usually has a very significant negative impact on the progression of the treatment. So Professor Dato Razman Jamin, do you have any observations on this aspect in Malaysia?
Thank you, Dr. Takashi, for the questions. I think with regards to the skin cancer, perhaps I would give an input on general cancer management, especially during the pandemic of COVID. I think in general, I think for the whole countries, even under the Ministry of Health and also for the other facilities, we still treat cancer as our priority during this pandemic. So meaning that I think with regards to their follow-up, their management are still being taken care accordingly, but with strict protocol, especially because issues of the risk of infections. I think the strategies is basically we do have the treatment for them still ongoing. And if the public hospital were not able to provide that kind of facilities, example, limited resources for operating theaters, that's why we decant the patient to the private hospital for them to be taken care. And I do agree with you that I think there were significant numbers of cases because of the lockdown, especially during the strict lockdown, where the limited access, especially whether it's a known cancer patients or even a new established patient, they tend to present slightly later than what we used to see before that, because I think the worry of the resources that's available. So I think the trend in Malaysia may be similar with other countries. That's my opinion. Thank you.
So perhaps I can take the same question now to Sandra and Debbie. So do you think there's some digital solution for this? I mean, some sort of online diagnosis of cancer to catch people who are not aware that they have cancer yet, but will in under normal circumstances have gone to have their annual screening, but weren't able to because of the COVID situation.
Yeah, I'm happy just to say a few words. I guess cancer again isn't my area of expertise, but I am aware of work being done in Scotland with using digital health solutions to support cancer diagnosis, particularly skin cancer. And there are 2 or 3 solutions emerging in the UK that involve at-home photographing of skin cancers, and then either just through a remote service having those images reviewed very rapidly. But there's at least 3 companies that have now developed pretty sophisticated AI solutions where they can do image analysis of skin cancers very quickly and are pretty accurate at certainly excluding a lot of the ones that don't need rapid follow-up. So I think it's these sorts of approaches in terms of remote image analysis, AI, triage through these sorts of digital solutions that could make a big difference. And we're starting to see those used a lot more in the UK.
Yeah. Thank you.
Yeah, I don't have anything to add. Actually, I'm just aware of the same things. Teams working on for image of and working on AI and things like that too.
Yeah, I think there's great potential there too, and part of the things that you showed, Sandra, in your presentation, I can easily imagine being applied in some way to cancer diagnosis and also the AI analysis of big data to catch people who at the very early stages of the disease.
Exactly.
Right. Yeah. So let's go on to sorry. Oh, that was the only question in. I thought there were 2. I only see 1 now.
I think I might have answered the other one through typing, and it's meant that it's disappeared. So apologies for that.
Okay.
I think it was about upskilling of medical professionals moving into acute services.
Okay. Right. So then, as I said, I'll talk to the organizers, and we'll try to address any other questions that came from through email at a later date and share that with you. I think it was a very interesting meeting, and from my observation is that even though we approach this from the COVID angle and how new technologies, new approaches have worked to alleviate the impact of COVID on NCD care, I think, and this is just my view, but I think one thing that COVID has done is that it has highlighted issues and problems that were already there. And if there is a good side to the COVID pandemic, it's that it has accelerated the process of all of us adopting these new technologies, embracing them, and also driving innovation. And I think we saw part of that from quite a lot of that in the presentations today. So I think the next step, again, these technologies, it's not just for COVID situation, even when COVID is gone, hopefully next year, these technologies will become even more important in addressing especially NCD care, which in my view cannot really be treated in the conventional traditional healthcare model where patients will go to the doctor only and only when they start presenting symptoms. NCD is about, a lot of it is about prevention, early capture. And even though we didn't talk about it today, I think dementia is a typical area where we're seeing that the conventional types of treatment are really not going to be so effective. It's changes in lifestyle, and very early detection is going to be key. And I think the technologies which we shared today and also the approaches are going to be very important, those aspects too. So it's an area with great expectations and great potential too. And I hope that we'll be able to cover some more of those aspects in later webinars, which I hope we'll be able to hold in the near future. So that's all I have to say. We're about 10 minutes beyond schedule, and I apologize for that. But that's it. So thank you all to the presenters and the organizers. If there's anything you have to add or any notices, please go ahead. Is it okay?
Yep, all good.
All good? Okay, so then thank you very much, the presenters and also the audience. We're waiting for the questions. There's still some time to send them in, and we will try to answer all of them later on. Okay, so thank you very much for coming to the webinar tonight. Thank you and goodbye.